You're a very ethical researcher.
Right. So, welcome everyone. It's officially our new lecture by the Ukrainian Center for Law and Crime Research has begun. And today we have an awesome speaker that I'm really excited and enthusiastic to introduce. It's Professor Jenifer Carroll, who is a master in public health and a doctor of philosophy in anthropology. And she is a medical anthropologist, a research scientist, and subject matter expert on substance use and public health. And she's currently assistant professor of anthropology at North Carolina State University and an adjunct assistant professor of medicine at the Alpert Medical School at Brown University. Dr. Carroll has written a wonderful book that I'm just telling everyone to read, and the book's title is Narkomania, Drugs, HIV and Citizenship in Ukraine. And this book was awarded the Barbara Held Prize for Best Book in any area of Slavic, Eastern European, and Eurasian studies. And Dr. Carroll is currently researching the impact of drug-induced homicide laws on communities in North Carolina and the use of portable infrared spectrometers for drug checking and novel harm reduction strategy to prevent overdose. And I am just so excited to have her here in our informal online gathering to talk about Ukraine and her research, and that partly made our way into her book Narkomania. So let's give a virtual round of applause to Dr. Carroll, and the floor is yours.
Thank you. I'm so excited for the opportunity to be here and have this conversation. Хочу сказати, що я говорю українською мовою непогано, але не зовсім вільно, і тому ця презентація буде проводитися англійською. Ну, дуже дякую центру, який буде перекладати та давати субтитри на YouTube. This is great. I appreciate it. And I'm really glad to have this conversation. I do want to start by, this is not entirely shameless self-promotion, but I want folks to be aware that the data I'm talking about today is from the book that that Daphne just introduced for us very kindly. And we have recently gotten a grant from the American National Endowment for the Humanities to make it free electronically. So if you have any interest, the book is in English, but if you ever want to see it, you select the ebook option, hit free download, you can take a PDF, boom, there it is. So easy. So in 2 seconds, the book can be yours if you want it. And I encourage anyone who might be interested to do so, because yeah, I'm very happy that it's free. So I will start my presentation. Oops, excuse me. All right, is that looking like it should? Yeah. All right. So I was asked to talk about, I'm very excited to give this talk because I was asked to talk about a chapter or a section in this book that I don't often get asked to talk about. Certain chapters are about Euromaidan or the Revolution of Dignity. I have chapters that are about street drug use. I have chapters that are about the annexation of Crimea, and those tend to be the very exciting and sexy topics. But I also have some chapters that are about very boring topics like paperwork. As an anthropologist, I actually find that mundane, boring material really exciting because even though we often think of it as something that is just work and frustrating and very, not interesting at all, I think it's important to pay attention to even the details. I guess that's my priority as a social anthropologist. Even in the most boring things that we do, why are we doing it and what are the impacts of it? Especially when I'm giving presentations to American audiences, I like to share this quote with them from the classic film «Служебный роман», «Если бы не было статистики, мы бы даже не подозревали о том, как хорошо мы работаем». So if there were no statistics, we would have no idea how well we are doing. And this is, after I share this quote with them and explain to them the movie and what it's from and why it's a joke, I take up anthropologists' favorite activity, which is to explain the joke that we have just told and to help people understand why it is funny, it makes us either your very most favorite or your very least favorite guest at dinner parties, temptedly. But I found this joke very funny. I think most people find it funny because obviously, if we're happy in life, if we have food, if we have the ability to travel, if things are well, if we're not wanting, if we're healthy, then obviously society is working fine. And the idea, though, that we can only recognize how good we're doing if we have statistics is sort of a joke about how many things were monitored and how many statistics were kept, and the fact that we create value through statistics. I think this joke tells us how much social value and social meaning is put into not only the data in statistics and paperwork, but the sheer fact that we have that data and paperwork at all is something that has value. I want to make what feels like the very obvious observation that paperwork is work. So when we're looking at what bureaucracy and paperwork and statistics mean, what kind of social work it does, what kind of symbolic work it does, many social scientists and cultural scientists pay attention to a couple of things. One is that someone has to do it, and two, that determining who should do it and why they should do it and precisely how they should do it and how often they should do it. These are all social questions, and it requires people to organize themselves, to create a certain type of social relation, to determine who should be the monitor and what should be monitored and why those responsibilities are doled out and what the moral implications or ethical implications are of failing to do it. So these are places where paperwork develops social meaning. I have an example for you that folks might appreciate. This is a receipt that I was given back in 2016 when I was having a picnic with some friends at the Expo Center in Kyiv. I used the public toilet. I paid 3 hryvnia to get in to the public toilet at the time. I thought nothing of it, and I finished and I left to go back to my friends, and the attendant, the woman who was working at the bathrooms, monitoring the bathrooms, yelled at me. She said, "Девушка, stój," and ran and came up to me. And when we met again, she said, "Wait, your check," and did her little, procedure and printed out this check and handed it to me and was like, "Yes, there you go," and walked away. And I came back to my group and I just said, the funniest thing just happened to me. Like, this delightful woman really insisted on giving me a receipt for the 3 hryvnia that I paid to go to the bathroom. And I joked like, "Oh, should I turn this into my university maybe for reimbursement? I don't know." And a friend of mine who lives in that neighborhood laughed and he said, "Oh yes, I know this woman. She is very proud to be the least corrupt woman in all of Ukraine." And so for her, just being able to produce the paperwork, that was sort of a moral action for her. That was how she presented it to me. It's clearly how she had presented it to my other friends who had used the same bathroom on previous occasions, that this is how we act in a society that is transparent, that is not corrupt, that is above board. And so just producing the paperwork, even though I knew that this receipt was not useful to me, she knew that this receipt was not useful to me, but having the receipt created a shared understanding about our social values together. I also want to make the observation that different kinds of data produce different kinds of knowledge. And that may seem obvious, but I want to unpack some of those implications for us. These are 2 photographs that I took from a book that I'm currently teaching in my Introduction to Cultural Anthropology class. The book is by an American anthropologist named Johanna Taylor Crane. The book is called Scrambling for Africa, and it is about global health programs, especially global health programs sponsored by American universities and American government institutions, being implemented in Uganda, in Eastern Africa, during the early 2000s, especially when international and state agencies were allocating a lot of money, beginning to spend a lot of money and build programs to respond to HIV. So the PEPFAR, or the President's Emergency Plan for AIDS Relief in the United States, the Global Fund, which has a lot of involvement in public health in Ukraine, still all of these organizations. And what she noticed while watching these institutions grow and seeing their influence change how care was delivered in Ugandan hospitals, she noted that before American physicians and American universities became involved, the picture on the left, the handwritten document in a notebook, were the kind of medical records that doctors would keep. And this is because they did not have a formal health record system. They did not have an electronic health record system. And so this is an example of a visit. The date is August 2005, and you can see that the doctor has recorded which patient, their weight, their blood pressure, their body temperature, their CD4 count. On the bottom is actually a little doodle, a little drawing of their lungs, which were clear, and their abdomen, which had no masses. And this is a way in which these doctors were keeping track of how patients were being treated and how they were doing. And I, to be honest, have to say that I keep similar documents about my students: who has come to office hours, who's asked for help, who's struggling on the exam, what are we doing? And on the right, I know it's hard to read, but I think the words are not the point. The form is the point. The standardization is the point. This is the new kind of health record form that was brought to the Ugandan hospitals by American universities, by American scholars, and by American funded research. And this is very standardized. It's very detailed. Mostly it's clicking buttons, checking boxes, not a lot of room for writing opinion or elaborating, things like that. And part of the reason why there was a big push to have this more standardized, formal type of data collection is because standardized data, standardized statistics allows us to do analysis, right? If we want to compare how patients in this hospital are doing compared to patients in this hospital, or patients on this kind of treatment versus this kind of treatment, how they're doing, the information we have about them has to be the same so that we can compare them next to each other. And the handwritten document doesn't allow us to do that. The National Institute of Health, American scholars, many people insisted that the form on the right was the correct way to do it, or the better way to do it. And what I would argue as a social anthropologist is that one is not better than the other. They simply produce different kinds of data that produce different kinds of knowledge. So the one on the right produces standardized data that allows people to be compared, but it doesn't capture things about, what's happening with the patient. How is their marriage going? Are they getting evicted from their apartment? How are they doing? How is their pain? Are they able to pick up their kids or walk to work every day? Those sorts of deeply personal, relational things. On the right, you lose the capacity to compare data and to have these big descriptive statistics, but you can capture some of that personal stuff, right? So even after the standardized form happened, some doctors still kept the other ones. One could be better than the other, depending on your goal. Both of them produce different kinds of knowledge, and that's, I think, the big takeaway. So you may make the claim that one is correct if you assume that there's only one type of use for that data. So the research that I did in Ukraine was largely motivated by my desire to learn about what was happening with public health programs to control HIV. And so as someone who was just starting to learn the Ukrainian language, just starting to learn the Russian language, just starting to learn about Ukraine, especially in the United States, this was sort of the picture that was presented to me, that there is a large HIV epidemic, that it's not necessarily under control, that Ukraine and Russia and Belarus as well are particularly impacted. And I felt that there was something obviously more nuanced, more interesting going on, and I wanted to explore. The Ukrainian HIV epidemic is very interesting from a public health point of view, because in most parts of the world, the primary driver of new HIV infection is sexual contact. And in Ukraine, that is now true. And if you see the red line, or with the squares that kind of goes up, that is the rate of new HIV new HIV transmission from sexual contact. The blue line, or the line with the diamonds that kind of does an arc, this is HIV transmission through syringe sharing, through blood, through intravenous drug use. And at the beginning of the epidemic, I believe the first, if memory serves me correctly, the first HIV case in Ukraine was identified in 1996. So, more than almost 2 decades after it was first recorded in the United States. Syringe use or injection drug use really dominated the driver of that epidemic. So a lot of programs were put into place to respond to that among people who use drugs specifically. And those are the types of programs that the Global Fund was paying for, and that PEPFAR were paying for. And you can see that they have worked, essentially. So even while HIV continues to spread among sexual contact in the general population, HIV is starting to be controlled in the population of people who use drugs. And so there were 2 major methods that were used to help slow down the HIV epidemic in people who use drugs in Ukraine. And these are scientifically proven methods, which means that they have been implemented and studied in many parts of the world. And we know that they consistently have great public health impact and very little negative impact, or no negative impact. So many people who are not familiar with the science or the evidence behind these strategies might very reasonably wonder if, for example, this might make public health worse, if this might encourage drug use, increase drug use, cause more crime in a community. And we know from study after study after study after study that is not the case. So these 2 primary strategies are syringe exchange or syringe access. So making sure that people are able to use sterile equipment, because even if you are using injection drugs, you will not transmit or be infected with HIV, hepatitis, or anything if you are using a brand new, clean, sterile syringe every single time, just like someone who uses syringes for insulin therapy for diabetes, or I use syringes at home for allergy injections. I have a new syringe every time. I'm at no risk of being infected with a virus or transmitting a virus to anyone else. The second strategy is medications for opioid use disorder. So treating people who have addiction to opioids with medication to help them cease using street drugs and injecting. And we know that these work. So syringe access, or distributing new, clean, sterile syringes, this is just one example, but in many places we have seen sufficient distribution of syringes stop HIV epidemics. This is an example from Philadelphia where really robust syringe access, I mean, you can see it taper off. This single-handedly helped control an HIV epidemic in Philadelphia, and now the rate of new HIV infection among people who use drugs is extremely low. This is actually a picture that I took with a nonprofit organization in Lviv, where they are very busily handing out syringes to people who are there. These are the empty boxes that were going to the trash or to the recycling after only 1 day of delivering services from their van. So they're doing really, really excellent work, building positive relationships. Yeah, it's a fabulous, fabulous organization. Now, anybody who uses syringes can benefit from a syringe access program. Treatment for opioid use disorder or treatment for opioid addiction is only appropriate for people who have opioid addiction. And I want to remind us that using drugs and being addicted to drugs are not the same thing. This is data from the United States. We don't have epidemiology that is this detailed in Ukraine right now, so I'm using the United States as an example. The middle column with the tallest bar is our national estimate of the number of people who are using heroin and the number of people who are using prescription pain relievers or prescription opioids, tramadol, oxycodone, Vicodin, things like that. And on the right is the people who have the disorder. And so we can see that for prescription pain relievers, it's actually pretty small, only about 1 in 5, less than 1 in 5 people who are using prescription opioids, whether they're swallowing them, inhaling them, injecting them, only a few have an actual disorder. With heroin, the prevalence, the proportion, the ratio is a little more, but the definition used for disorder in this particular study is kind of loose. So in reality, the number is a bit smaller. So briefly, the disorder, we tend to stick with the definitions that come from standardized codes. So in the United States, that's our Psychiatric Diagnostic and Statistic Manual. Internationally, there's the International Code of Diseases, or the ICD, and those symptoms or those definitions tell us that opioid use disorder is a behavioral disorder. It has psychological, biological, genetic, emotional, and social components. About 15% of Americans will meet the criteria for addiction at some point in their lives. I should probably update this slide because I believe the current estimate is more like 20%, and that includes alcohol and that includes tobacco. But the point being is that this is a thing that many people experience and live with. And it's characterized by a couple of things. One is tolerance, which means that you need to, your body gets used to the substances you're taking. And so if you want the same effect, whether it's euphoria, like a kaif, or whether it's pain relief or something else, you might need to take higher and higher doses to hit that, that goal. Withdrawal, which is that if you stop taking it, your body will have a withdrawal syndrome, which could be fevers, shaking, sweating, nausea. It can be really bad. And tolerance and withdrawal are things that happen with a lot of drugs, benzodiazepines, opioids. Anyone who has been on antidepressant medication for more than a few weeks will experience withdrawal. So it's important to know that those two characteristics alone do not are not sufficient to label someone as living with addiction. Even someone who's taking a necessary medication under doctor's supervision will experience those things. That's just how our bodies interact with medications. It becomes a behavioral disorder when someone is engaging in persistent use, so they continue to use despite harmful consequences. So in spite of the fact that you are not benefiting from this, you are more often being harmed by it. Those negative consequences can be culturally relative. We find different things tolerable or intolerable based on our cultural values, but that's opioid use disorder. So medication for opioid use disorder is often it's the one that's available in Ukraine, we call opiate substitution therapy or opioid agonist therapy. So very similar to the types of patches and gums that have nicotine in them that can be really helpful for someone who is trying to quit smoking cigarettes. This uses the same logic, and it's a medication that is stable, that is pretty safe. It doesn't have the same kind of overdose risk as morphine or street drugs or street any opium, anything someone might be using. And this is something that people will take every single day. Excuse me. In Ukraine, 2 types of drugs are available for medication for opioid use disorder. The first one is methadone, which is sold under the name Metadict or Methadol, or buprenorphine, which is hard to say in English, and the brand name it is sold under is Etnox. So you might have heard of these, but these are daily medications that someone will take to help them manage their withdrawal. And really it helps people put this chaotic cycle of tolerance and withdrawal kind of on pause and manage some of the other challenges in their life that's leading them into chaotic substance use before they start challenging their body to step down. And again, this is a very, very evidence-based intervention. This is data from the city of Baltimore in the United States. The top jagged dotted line is the number of individuals on methadone. The bottom line is the number of individuals on buprenorphine or EDNOC. It was approved later, which is why it really only became available in 2002. And the red line is the number of fatal overdoses in the city. And we can see that as more people are gaining access to these medications, the rate of death goes down. And especially in the United States, where our drug supply is becoming contaminated with very strong opioids like fentanyl, carfentanil, things like that, we're finding that access to these medications is dropping people's risk of death by more than 50%. So they're absolutely life-saving medications. And if someone is on sufficient medication, then the idea is that they will no longer have a need to be seeking street drugs, to be injecting drugs, and that is how HIV infection is prevented. And they're synergistic, they work together. It's been demonstrated in the United States that even if someone is still using drugs, going to syringe access programs and gaining those things, people who visit those syringe programs are 5 times more likely to seek treatment with methadone or to seek treatment with buprenorphine than people who don't. So this is really based on relationships and support and kind of helping people make decisions in the at the speed and at the pace that they're willing to do so. So the research that I did was looking at these programs in Ukraine. I spent a lot of time, following people working for syringe access programs, hopping on the back of the bus and taking notes as people came in and asking them questions, hanging out in the courtyard of narcology centers where people were receiving methadone, buprenorphine, having my butt completely kicked at backgammon in a deeply humiliating way time and time again, and learning how people were using these tools to better their lives, to meet their personal goals. I made short visits when I was, the data that I collected was in 2010, 2012, 2013. And during that time, I made short visits to Odessa, Kherson, Mykolaiv, to Simferopol and Sevastopol, to Cherkasy. I went to Cherkasy a number of times, and Ivano-Frankivsk. And then I also spent longer periods of time, several months at a time, in Kyiv City and in Lviv, understanding how these projects were working. So those are the areas that my data is based on. Now, the Global Fund, which is a large international organization that works sort of like a World Bank, but for HIV and tuberculosis response, they have been funding syringe programs, methadone programs, and EDNOC programs in Ukraine since about 2004. The Ministry of Health, the National Ministry of Health in Ukraine, began allocating money and dedicating money to purchasing those medications for the first time in 2016, 2017. So for about 12 years, everything about these programs was being supported by the Global Fund, purchasing the medication, paying the nurse salaries, buying the light bulbs, everything. And the grant coming in from the Global Fund was managed by an organization that today is called the Alliance for Public Health in Ukraine. It's a nonprofit group who has done a really amazing work running these programs. I have to pause and say how wildly impressed I am by these folks. They received this massive grant from the Global Fund with very little notice. I think the average staff person there was like 24. They had maybe 10 people working there, and they just collected and organized and have been doing such impressive work for such a long time. But with that generosity, with that philanthropy of money coming from the Global Fund, there's also obligations that come with it, right? There's reciprocity that's needed. So part of what the Global Fund wants in exchange for providing this money to support these programs is data. They want to know what people are doing. And partly that is about making sure that money is being spent ethically, that there is no corruption involved in giving these donations and these big grants of tens of millions of dollars. So this is a direct quote from a manager who is working at the Alliance for Public Health. It may also bear noting that most of the leadership in the Alliance for Public Health in 2010 had received Masters of Public Health degrees from American universities. So their English was 10 times better than my Russian at the time. So most of our interviews were in English. And this individual said, the Global Fund requires us to follow the money and look at where it's being spent. Is it going to the program or not? So there's a lot of program monitoring that's connected to this issue. There's financial monitoring also, which is separate, like audits. We have an audit which tracks all the spending accounts and books, but as far as programmatic monitoring, we just want to make sure that we are reaching the clients, that there is coverage, that we know they are receiving what we are procuring. And this quote to me illustrates two things, and that is that, well, three things. The first thing is that a lot of energy is put into collecting data and doing paperwork. This particular individual told me that they have 2 full-time staff members, which is not cheap. So 2 full-time staff members whose only job is to collect data from all of the programs and the different oblasts that are using this money, and put it all into a database so that the Alliance can see how are things working, and then to repackage that data to answer the questions that the Global Fund is interested in and send it back to the Global Fund. So these like full-time data accountants who are just managing numbers, right? Not using the numbers, not analyzing them, just managing them. And then the other two things are that there's 2 pieces of work that this data collection is doing. First is about the Global Fund. The Global Fund is really interested in knowing where the money is being spent. They want to watch what's happening and make sure that everything meets their approval, that it's according to their rules, according to their guidelines, and that the programs being operated are following those evidence-based best practices. I shared earlier that these are evidence-based programs. There's science behind them, there's studies behind them, but it's possible to do them badly, right? You can run a program very poorly or very unskillfully, and if you're not leading this kind of effort the right way, then the global health is worried that the public health benefits, that the individual benefits will decline or will be reduced. And so also the Alliance is interested in watching the organizations. And she said not only the same thing, making sure that the organizations are spending money as they're supposed to, but also making sure that they are doing the evidence-based best practices as well. The Alliance, when she says to know that they are receiving what we're procuring, the Alliance is buying all these syringes. The Alliance is buying all the condoms and then giving them out. They want to know that they're going to the people that they are intended for. So we have a term for this in social anthropology called audit culture. And this is a term that was generated or first produced and discussed by a social anthropologist named Marilyn Strathern. And audit culture, in her definition, is the process by which the principles and techniques of accountancy and financial management are applied to the governance of people and organizations. And so to put that in more simple language, it's the way of using paperwork to monitor and control people, or to monitor and control organizations, which is exactly what the Global Fund said they were doing and what the Alliance said that they were doing. So at the Syringe programs, especially the ones that I visited, I actually still have this, this sheet of paper right here. I collected this in 2006 at a Syringe Access program in Odessa. If you ever live with a social anthropologist, you will know that we don't ever throw anything away. Someone will be like, is this garbage? Can I take it outside? I'll say, no, it's an artifact. I have to keep it forever. And this is why. So this is the form that the Alliance had produced according to the regulations of the Global Fund to distribute to everyone offering these syringe service programs. And you'll see that there are some expected things here, right? So you'd have the date that this happened, the week that this happened. On the far left is the code clienta, which is instead of writing down someone's name, and you could say like Natasha came to get syringes so that she could use drugs, it would be client number 458, you know, and that would be connected to Natasha over in some very protected filing cabinet or encoded computer data somewhere. Did they take 1 syringe, 2, 10, or 20? How many did they return? Did they take materials? Did they meet with a doctor? Did they meet with a psychologist or a lawyer? And every single client contact is maintained in this clear way. And this helps the Global Fund do a lot of analysis about what is working. So every time you see someone, how often are they coming? Every time you see someone, of all the clients that come in, how many are doing their laundry? How many are seeing a doctor? How many need this? It's monitoring need, it's monitoring the efficacy and the success of the organization. And this is very big data, comparable data from all groups. But one of the things that I found while I was there is that, yes, even though this is our example from a hospital in Uganda, I did not take pictures of anyone's personal notes when I was in Odessa. The people working at this exchange nevertheless kept these notebooks. And one of the reasons why is because there were particular limits on the amount of syringes that could go out. And so, for example, at some places, the limit of syringes that they could distribute was 10 per person. In other places, it was 20 per person, right? And so, in principle, to get those 10 or 20 syringes every day, you would have to yourself show up at the syringe exchange, be like, hello, thank you. You'd say, like, here is my my club card, right? My membership card for the program. Here's my client number. They would see you, they would say hello, write down your client code here, write down what you took out, and then send you on your way. However, what was happening at this time in 2006, 2007, when I was in Odessa at this program, is that people would come in and they would say, hey, you know me. I have my girlfriend at home. I have my best friend at home. I have 2 roommates, and then I have my neighbor. I'm coming here for 6 people, including myself, right? And so this is what we call today secondary exchange. And this is today a very, very normal way of running these programs. We'd say, like, oh my gosh, did you come in all the way from, like outside of town? Did you travel 100 kilometers to be here? Obviously, we're not going to give you 10 syringes. You're going home and you're meeting lots of people who are in need, who can't come here themselves. We're going to give you a lot, and we're going to let you give out those things. And that helps improve coverage. It really boosts the public health benefits and the HIV prevention benefits of these services. And today I'm working with a program in North Carolina who has received a federal grant to improve that secondary exchange. So to find very active participants, active clients who can be trained to be their own satellite distribution points. So today this is considered very normal and a best practice. At the time it wasn't. And so in their notebooks, the people at this organization would keep a second set of records, right? And you could call it like 2 sets of books or double bookkeeping, where if someone came in and said, hi, I'm whoever, this is my number, I'm getting syringes for 6 people, they would give that person 60 syringes. And in their handwritten book, they would write this down, but they would also know who this person is, and all of their friends would be registered, and they'd be like, oh, you're 458, but you're friends with 620, you're friends with 311, you're friends with 219. And so they would go into this book that almost had a map of the social networks of everyone who was there. And so instead of writing 458 got 60 syringes, even though 458 is the only person that showed up that day, they would write 458, 10, 311, 10, 219, 10, and so on and so forth down the row, even though those other people didn't show up. And so this attitudes towards this behavior have changed over the few years. And I mean, especially when I tell this story about this particular bookkeeping strategy, I have seen the attitudes of my audience members and the people I'm telling it to change over time. Today, especially in the United States, where we have a very positive view of secondary exchange, no one questions this. It makes total sense. In 2007, when I first shared this, people got angry. They were like, this is corruption. This is mismanagement of supplies. This is double bookkeeping. This is immoral. And, the argument that I made at the time, and which is now fortunately becoming more commonly held, I think, is that there's not really a conflict here. And it's because, as I said before, this is two different kinds of data keeping, and they serve two different purposes. They create two different kinds of knowledge. The fact that they're different doesn't have to mean they're conflicting. It doesn't have to mean that this is corruption. It means that they need two different kinds of data. So if we look at it this way, what are the things that the Global Fund wants to know, right? They want to know, are supplies being purchased? Are they being distributed? And does that distribution follow best practices, right? And those questions are being answered by this form. They know who it's going to, they know what is going out the door, they know how many clients have been reached. And in fact, that's almost a more accurate way of keeping data for the Global Fund by putting down the numbers of people who never showed up, because the Global Fund wants to know that those people are receiving service, whether they were inside the office or 10 kilometers away or something else, because the goal of this is to enforce good behavior from Ukrainian organizations to say, are you doing the job of reaching as many people as possible, of distributing supplies to as many people as possible? And that kind of record keeping, staff members had to make decisions. And as they made decisions, think about, how can I record this on the sheet of paper that I have to turn back into the Alliance, that the Alliance is giving to the Global Fund? So it shaped the way that they did that kind of work. And in fact, this goal kind of justified them maintaining the second book, because the second book contained a different sort of information. It asked things like, what social networks and relationships exist among our clients? Who is accessing supplies even if they don't come in person? And how are we reaching people, right? It's useful to know if you're reaching person A because they come in every day, and you're reaching person B because person A reaches person B. You know who you're touching, what your relationships are, how to deal with that. So the goal is more how to provide personal care and build relationships, right? So that to me is, I think, a really, really interesting example of, it's possible to look at this and think that this is sort of double bookkeeping and bad. And it's possible to look at this and say, no, this is great and a really good public health practice. But whatever it is, each type of data helps them do different work and answer different questions. The thing that I focused on more in my chapter was how the standardized sheet, this funding required staff to think about what they were doing differently, because it still had to be written down in some way. But this is not the only type of paperwork that was demanded by folks that were in this line of work. This is actually some photographs that I took while I was observing in a opioid substitution therapy clinic located in Speed Center, in one of the Oblast centers that I visited, so in an AIDS hospital. And so what you see on the right is every patient's methadone dose. Imagine going into your purse and pulling out coins to get a particular amount. It's like, this is how they did it. This person needed to have maybe 72 milligrams of methadone, and the long bars have 20 milligrams and the tabs have 10 and the little one has 2. So they're adding up pills to get someone the correct dose for their person. And the paperwork on top is something that the doctor had to keep every single day. His desk was covered with them, actually. And I was told that these were documents that were reported ostensibly to the Ministry of Health. Often they weren't asked for, but if they were asked for, he had to produce them. So he needed to maintain them, and that there were actually multiple kinds, and that the people who came to ask for these documents and prove that they existed most often were the local police. And the local police claimed that they were following the orders of the regional or the oblast health authorities in monitoring this program. So this is what his desk looked like when I came in, and every single one of these papers was in rotation constantly. And so these are the documents that he was told he was required to keep, and I saw him do every single day. So one of these lists has the name of the patient, the medication dose, and the date of the dose. So basically the doctor writing a prescription for specific milligrams of methadone every single day, and the doctor has to sign it. There is a second sheet of paper to show that the dosage had been delivered to the patient, that the patient had consumed the dose, and that was signed by the nurse, it was signed by the patient, and it was signed by the doctor. And then a third document recorded the date and the time that the patient was physically at the clinic that day, and it had to be signed by the patient and signed by the doctor. I imagine that they had an enormous budget just for pens, because this was just so much ink every single day. And he had binders and binders and binders, like boxes of these papers in his office that he had to produce on demand. He said sometimes they were useful because every now and then the police would come and they would say, hey, there was a crime, there was a burglary that happened. We think it was so-and-so, you know, like tell us where Tolio was at 10, and he can open it and say, oh, Tolio was here at 10, it wasn't him. So every now and then this was a little helpful. But I found this perplexing. Even our most classic jokes, you know, about like statistiki and like all of our stereotypes about older Soviet methods of keeping record keeping and the legacies of that today, like even that didn't explain all of this. And part of the reason why I thought this was so strange is because these documents, they're not digitized. And what that means is that you can't put it into Microsoft Excel. You can't put it into SPSS. You can't put it into a software and say, describe to me what is happening. There's no way to use this without spending hours and hours and hours entering this data into a computer. It does not show how well or how treatment is working. So if you're interested in whether a patient is on an appropriate dose, if you're interested in whether a patient is succeeding and has stopped using street drugs, if you're interested in whether or not a patient is satisfied or wants to quit tomorrow or is new, like none of those variables are captured. This is not helpful data from a medical standpoint. It's not helpful data from a public health standpoint. And they're useless. This is really useless data on a lot of levels. And yet the doctor kept these every single day. Because what I understood was the point is not the data. The point is making people do the recording and to produce the recording. The point is to make people do the work. Okay. Why? Why do we make people do all of this work? Well, in social anthropology, we have this term this idea that's used a lot in describing how objects, inanimate objects or processes that are not human can be embodiments of social power. This is not a term that we use in the United States, but in the United Kingdom, in England, it's common to call bumps, like speed bumps on the road to keep your car slowed down, to call it a sleeping policeman. And the idea is that these bumps on the road are there so that you, no one has to be watching you. No one has to say, hey, slow down, follow the speed limit, be less, chaotic in your car. You know that you're going to have a negative consequence if you don't follow the rules because the bump is there. And so you police your own behavior. You control yourself. We refer to this as discipline. We mean it the exact same way as you might say to discipline a child. You give a negative consequence so that the child will not do that thing anymore. So they will not touch the hot stove, or so that they will not pull the dog's ears, or whatever thing that is inappropriate for them to do. And the child will control their own behavior. The purpose, I argue, of all of this paperwork is to make people constantly aware and have every motion of their day reinforcing the idea that there will be negative consequences if they don't follow the rules, especially from police. So this is a different program officer from the Alliance for Public Health that I interviewed in 2010, who said they being the police who are monitoring all this paperwork, want to create a culture of fear. They create rules that no one can possibly follow so that you are always in violation of something. And that way they can threaten you with consequences anytime you have upset the wrong person. And I probably don't need to explain it to this audience, but this is not just a theory. This is something that we actually see happening. There were several instances actually of physicians who worked in methadone clinics who were providing this evidence-based, internationally supported form of care being arrested in their homes and charged with drug trafficking because they were giving people methadone and EDNOC without the proper paperwork, right? So if you do the paperwork, it's healthcare. If you don't do the paperwork, it's drug trafficking. And there was I think for him, the problem was not even the document signed every day. It was that his clinic moved, or maybe even the name of the road his clinic was located on changed. And so there was like paperwork at the oblast level that didn't line up. And they were like, well, you've just gone from a doctor to a drug dealer overnight. So we know that this is used to harass folks who provide medication, to harass people who use drugs, and to really give them a hard time because the police are taking a very different view to the people who need this. And this is, I think, the big takeaway for me from all of these different kinds of paperwork and what they mean, is that each of these paperworks are assuming a different type of understanding about people who use drugs. These are not exclusive, right? So it doesn't mean, there's no overlap. There's always overlap, but it focuses on specific things. So the big standardized public health international organization document is focusing on, these are individuals who need highly specialized care and services. And specialized means following the rules, following the evidence, doing it the right way, maximizing the public health content, the public health benefit of all of this, right? The notebooks, the social networks, the records that social workers kept when they were doing this work pictured and imagined people who use drugs as folks with relationships, people with whom relationships can and should be built through care and support. So this was about capturing them as human beings. And this paperwork that the doctor at the Speed Center was filling out, this assumes and sends the message over and over that people who use drugs are dangerous or deviant and who need to be supervised, controlled, and contained, right? And so this is being done by two ways. One, making them feel like they are being watched all the time by signing the things, investigating their bodies to see if they did swallow the methadone, all of this monitoring. And two, because I said earlier, it requires social relationships to come together, right? Someone has to be responsible for creating all this. And why is it your job? And who should be monitoring and who should be monitored? It forces the physician into a position where they are responsible for monitoring people in their clinic, not in a medical way, but in an almost criminal way. And so it can be twisted to say that you're doing criminal activity if you're not participating in monitoring your patients as though they are criminals, right? And ultimately this matters because the way that we view people who use drugs fundamentally changes how we provide those services. But this is not only true of these services of people who use drugs. Even the way that we record learning, the type of exams that we give in schools will change how we teach our children, right? It will change what we think about as our goals or what we have to accomplish. This is actually a really big conversation, has been a big conversation in the United States for a long time about standardized testing in schools. And the worry is that we're leaning on these standardized tests so much that now our teachers are really focused on teaching the test and not about broad, individualized, robust learning, right? So the paperwork shapes our goals, the goals shapes our action. And we know that if we have stigma or criminalization buried in our paperwork, then people will feel stigmatized and people will feel as though they are being treated like criminals, and that produces barriers to care. It makes it less likely that people will seek care. It means less effective public health treatment, and it has real public health consequences. And so that's, I think, my argument as to why paperwork is not boring. It actually matters quite a lot. So that's the end of my presentation. I want to acknowledge the Wenner-Gren Foundation and Brown University who supported this work, and then the Alliance for Public Health and the Ukrainian Institute on Public Health Policy, who were not formally involved, but their staff has been so generous, and I have learned an astonishing amount from the people who work there. They're real geniuses who are doing that work, and I'm grateful for their generosity and their welcome to me constantly. Right? Yeah. So thank you very much. I appreciate you all being here to listen.
Thank you so much for the wonderful lecture. I mean, I was just hypnotized. I was looking at the screen and.
Oh, you're very kind.
Really, it was the highlight of my day.
You're very kind. Thank you.
Well, before we open the floor for questions, I wanted to use this privilege of being a moderator and asking the first question, if you don't mind. And actually, I have two questions, but they're like more like parts of the same question.
I accept this, yes.
Thank you. So when you were in the field, I was just wondering how did your participants react to your interest in their bookkeeping practices, in documentations? Weren't they trying to be protective of it, like, oh, this is something that you don't need to know, or something like that? And then when you actually published your book and you quote unquote revealed their secrets, in your book, was there some kind of maybe like angry, or what was the reaction of your participants? Weren't they, I don't know, like angry or discontent a little bit that you kind of like reveal these practices of double bookkeeping that people in Ukraine are sometimes kind of like touchy-feely about?
Yeah, those are great questions. So when I was collecting data, people were actually, they thought that it was very cute and funny that I was interested in paperwork. I had this really expensive camera that I had bought with grant money. And instead of taking photos of like the beautiful Carpathian Mountains or like people, I would be like auto-focusing, using it like a scanner and taking pictures of all their papers. And they're like, well, this American is a very strange person. We don't know what she's doing. So usually they found it uninteresting. Sometimes they were proud of it. So like this, for example, I was able to collect and talk to people about because they were like, yeah, this is a lot of work and we're very good at it. Right. You know, and so the ability to just like produce that kind of evidence in a skilled way, because, you know, going off of the observation that paperwork is work, work takes skill. Even if we think about science, like laboratory science, as something that is like above society and is this pure objective data, like anyone who has ever done a chemistry lab, maybe at university, knows how easy it is to be unskilled and like ruin your experiment and everything goes awry. So there was some pride that they were managing all of this really messy data skillfully. And then at the Speed Center, for example, with all of the documents that the police regularly checked, folks were very happy to have me look at it because they were like, can you believe this? This is awful. Look what they're doing. Take a picture of it. Tell people what they're doing. And the response was more a desire to anonymously complain and anonymously illuminate something that they found very unfair, because they knew I was not taking pictures of them and writing down their name. I could just be like, a very skilled doctor said this is bad. And as far as responses, I think two things. One, it is really, I can't understate I can't overstate how much the policy environment has changed in Ukraine from the time when I first did this research to now. So I think that I hope that the observations that I made and the conclusions I was able to draw continue to be helpful in understanding how society works and how these public health programs work. But like the same paperwork is not being used. The same regulations are not necessarily in place. And I think that folks at the Public Health Alliance are way too busy to read my book, honestly. So if anyone is upset with me for talking about this, they have not told me about it. My hope is that they are not, because I tried to take the time to be sure that I was not writing anything offensive or saying anything offensive. So that was my goal. But I may be wrong. Yeah.
No, I'm pretty sure that you're right. I mean, I read the book and I think you're talking about like everything like very ethically, and actually this is one of my favorite chapters, as I probably said before. So I think that I've been talking too much, so maybe there are some other questions from folks in the audience. I think that this is a fairly informal gathering, so maybe people can unmute themselves and just speak up if they have questions, but also if you feel particularly shy today, that's okay as well, and just type your question in the chat and I can voice it for you. And also feel free to type questions in Ukrainian in the chat and we will translate them for you. Go ahead, Maria, I guess.
Okay, so it's not exactly a question, but
Sure.
maybe a topic which we can discuss now. It's topic about digitalization. What I feel now that, first of all, I saw a lot when digitalization started in Ukraine. It was, I think, several years, and now it's continue in some places that. Doctors need to do paperwork twice, actually,
Yeah.
one digital way and another in paperwork. But
Yeah.
now it's a bit better. But I think new issue arise, the most typical visit to doctor now, it's like two minutes talk and then 10 minutes doctor talk with computer actually.
Yeah.
And I wonder maybe we with this digitalization trends we lose something in interaction between doctor and patients, and maybe we need to put it in question and there is balance between useful, clear, nice data for our super researchers and the feeling of sensible work. I don't know.
Yeah, I think that's a great observation. I am aware a little bit of the trend toward digitalization in clinics now. I know that there was this dream that the National Health Service would create a unified electronic health record system for Ukraine. And when the idea was first presented to me as a researcher, I was like, oh, this is the sexiest idea. Like, this is going to be great. I don't believe that has come to fruition. I think they made the plan and never put out the contract. But what you're saying is the same that I have heard doctors in the United States complain of as well, right? Because while who is we? Scientists and policymakers like to really focus on the benefits of the data, we sometimes forget to think about the fact that paperwork is work and it takes time. In the United States, some health systems have scribes, so literal transcriptionists whose entire job it is to take physician notes, physician recordings, and put that into the healthcare database for the doctor. But again, sort of like the two staff persons at the Public Health Alliance, that's a whole individual, a whole salary, that's not cheap, right? And it does take away time to have to enter this kind of data, the same way that it takes time away from teaching in the classroom to stop and do a 3-hour-long standardized test. So that conflict is hard to overcome because it's also challenged by the fact that healthcare systems, healthcare leaders want to be efficient, and the definition often given of efficient is seeing more patients. So perhaps the solution would be, well, we can't meet with a patient for 10 minutes. We need at least half an hour, maybe even a full hour to talk and understand, and then pause after the patient leaves and then put everything in. But that means that you see fewer patients. And when your healthcare system pays clinicians, pays doctors by the patient, so your National Health Service pays by the patient, our national health service, we don't have a national health service, our federal safety net healthcare and our insurance companies pay by the visit. So if you see 8 patients in one day, you'll get paid twice as much as a day when you see 4 patients. And so these pressures don't really, they conflict with one another. They create these competing challenges. I don't think that anyone has come up with a great solution for it yet, other than, maybe magically create twice as many doctors overnight. So yeah, I think that's a very important conversation to have, and it's very important to listen to doctors and what they're frustrated with, and to listen to patients about what they're frustrated with. I rarely hear leaders or policymakers suggest that we compromise the data. I rarely hear people say, okay, then we can't collect the data then. Usually the data is like sacred and other things have to shift around it. But there are some examples out there, not in healthcare, but in charity, like international charity. I like to refer to Heifer International. Heifer is like a fancy English word for a cow. This is a group that gives livestock, gives animals, cows, chickens, goats to impoverished families living in rural parts of Africa, rural parts of India, and they don't collect any data. They have no outcome statistics, nothing. And they're just like, we're pretty sure it's helping to give someone a goat who has no food. Like we could spend money collecting data, but no, we're just going to buy more goats. Thank you. And so like there are some people who are resisting the trend for big data, but yeah, I don't see it much in healthcare. I think that's going to continue to shape how these digitalization processes happen. And it's probably a lot of people are going to be frustrated in the meantime, but yeah, it's a really, really, really important conversation. I'm glad you mentioned it. Thank you. Yeah. Ruslana asked in the chat, I'm curious if your informants also argued or agreed with my argument that the data you discussed was useless at the time of fieldwork, or if you didn't discuss it with them in those particular terms, do you think they would have agreed with you? So yes and no. The physician who is keeping that paperwork, he was the one who was like, look at this, take a picture of it. It's horrible. Like we're being oppressed by the police. And so he very, very much was clear that it had no purpose. It had no clinical purpose. It had no government purpose. The one benefit he stated was that, as I mentioned, the time sheet, so like this is the time a patient showed up, could be like an alibi if someone was accused of a crime, and that once or twice it had been useful for that purpose. But no, so he did not use the word useless, but he was very clear in sharing his opinion that it only served the purpose of making them feel watched. Yeah, so I guess to stick with my own standards, if you are a police officer who wants to harass drug users, then it is not useless. It's very useful, right? So depending on your goals, it could be useful, but from a clinical public health perspective, they agreed that it was useless. Yeah.
Well, thank you so much. And I was wondering, yeah, so, and now Cindy has questions, so probably I'll shut up again and you can just unmute yourself.
Thanks, Daphne.
First of all, thank you for your lecture. And I want to ask you like more broader question about like being a researcher from Northern America and coming to Ukraine, and how you prepare to this like journey in Ukraine, and maybe what do you read at the time about Ukraine? Maybe you can recommend some books or like articles about Ukraine for other researchers who also want to came in Ukraine and conduct their research here too.
Oh, that's a great question. So I relied on three things very heavily. One was, as you said, scholarship and other books and readings. Two was the generosity of my mentors and teachers in the United States. So my dissertation advisor is Dr. Lada Bilenyuk, who was born and raised in Lviv, Ivano-Frankivsk, Lviv or Ivano-Frankivsk, one or the other. If she watches this, I will have to explain myself. And other individuals who had been doing research, not just in Ukraine, but in Eastern Europe in general. And these people were so important to me when I had questions like, why is my landlord calling about this? Or how do I find apartment? Or like, did I really book train tickets? I think I booked train tickets. Is it real? And basic stuff, but also understanding how odd it feels. And I know Daphne and I have talked about this a bit, that like even if you are from a place you're studying, taking time away and then going back to that place as a researcher, as someone who is trying to take data and information, it feels very strange. And you feel like you are constantly begging people, which especially for someone who is socialized as a woman can feel very bad. So understanding those and normalizing those feelings. The third thing that was huge for me was the generosity of the people that I learned from. And when like American students asked me how I got by with my language skills, I said, you know, my language skills can always improve. I always have more to learn. But when I spoke to physicians and when I spoke to methadone patients and when I spoke to people who are working in harm reduction, right, or this znиження вреда, we call, I was like, the interest was there. The desire was there. They wanted to connect. They wanted to talk. It was a passion to talk about the work. And I said, I could go to the narcology clinic and we would talk about religion and politics and Bulgakov and all these detailed things. And then I would go to the Silpo and I would struggle to like communicate what kind of cheese I wanted because that person had no passion for selling me cheese, right? They were just like, you know, you don't even speak the language, go away. So when there was that interest in connecting because we shared a passion about the topic, it really helped. As far as learning about the area, the books. So the books that I read were largely American books because I was still learning the Russian language and still learning the Ukrainian language. And I am still a learner of these languages. But the American books were Catherine Verdery's What Was Socialism and What Came Next was very helpful for understanding not just history, but the impact of history on today, like how to understand the way places were still affected or to see the ghosts of old systems in current systems. I really appreciated a book called Post-Soviet Middle Class by Melissa Caldwell. I think Jennifer Patico is what it was. What was it? I can see the cover. Consumption and Social Change in the Post-Soviet Middle Class by Jennifer Patico. This book was actually about middle-class women in Western Russia, but it described how social relationships changed after the transition from the Soviet economy to the capitalist economy in a very Marxist, materialist way that made sense to me. I really appreciated Elizabeth Dunn's book called Privatizing Poland. In fact, this was sort of the inspiration for the whole paperwork chapter. The entire book is a story about the attempts of American food companies like Heinz, the people that make our ketchup, to purchase a baby food factory that was owned by the Soviet government and was being privatized and sold off. And how complex it was because the types of accounting kept by the managers during the Soviet period and the types of accounting that the American businessmen who wanted to understand the value of this factory on the market, like, did not mesh at all. They were completely contradictory. And so it was a great look at how knowledge is produced. And then there's a lot of really wonderful ethnographies in Ukraine. Lada Bilanyuk's Contested Tongues about language, Tanya Richardson's book, Kaleidoscopic Odessa, which is a deep look at culture in the port city of Odessa. And there's so many more, but I think those were the really big ones for me, the ones that especially shaped my thinking the most. Yeah. Mm-hmm.
I wanted to briefly build up on Sergei's question and to ask a few more, if you don't mind. So when you were thinking about the data that you've gathered, when you were in the field, did you actually find more helpful literature about specific topics like documentation or anthropology of public health, or was it just like more broad literature about the region that kind of like helped you to tie different threads together? And the second question is actually, how much this interest in data and accounting practices, was it something that you have developed before you have come to the field, or was it something that organically grown from the observation?
These are both good questions. So I think for me personally, the learning about the region was more important. And that's partly because I myself had been a staff person or a volunteer in these programs in the United States for a long time. So when I made my first visit to Odessa to visit a syringe access program there, I had been working in a syringe access program in Oregon on the west coast of the United States for like 3 years. So I obviously did not have a clear understanding of how the programs were operated and managed in Odessa. Like that's what I was there to learn, but I understood what they were, how they were supposed to work. And I was actually really interested in how similar the space looked. I remember telling someone in an email that like, I walk into the office and it's a syringe program. And if there weren't Russian on the posters on the wall, you would think you were in San Francisco, you'd think you were in Vancouver, Canada. I was like, how do they look exactly the same from place to place? But of course, they weren't exactly the same because we have big and small differences, big differences like different understandings of what the doctor's responsibilities and what the patient's responsibilities are in the clinic, different understandings of what services the government should provide and what services citizens should generate for themselves, but also small differences like how to be polite to people, whether or not like tea and cookies has to be a mandatory part of every single meeting, things like, so the culture, what was valued and prioritized and just the day-to-day management was very, very different, even though the structure looked the same. So I was learning about how, and this was really my question, is this program, this type of program, this type of intervention that I'm already familiar with, because I've been working in the organizations that kind of invented them for a long time. How is it being interpreted here? How is it being translated here? Because I would hear folks say like, oh yes, we studied your American way of doing it and we translated it for our Ukrainian people, And I would be like, okay. And then I spent the next several months trying to know. So I think that was the biggest for me. And then, remind me your second question.
And the second question was about your interest in the accounting practices.
Yes.
How did you develop it?
Both. So I actually decided to return to graduate school to get my PhD, which is how I ended up in Odessa for the first time anyway, because the way that we were keeping records in the syringe program I worked at was interesting to me. And I was interested in studying, I wanted to study anthropology. That's what I studied at university as an undergraduate. And the work that I did at the syringe program was between university and graduate school. But as I tell this story sometimes to my students here, I could say that my training in anthropology and just the fact that I'm strange led me to ask questions that the organization, the nonprofit, the local nonprofit I was working for was not prepared to ask. So at our regular meetings of the organization, the questions that we dealt with were like, how many condoms do we need to order from the factory next month? How do we manage the line by the bathroom? What do we do about the fact that Bob is being rude to everyone? And the questions I wanted to ask was, how are our enrollment practices and the things that we ask people to tell us when they sign up, like leading them to believe that we only think certain things are important about them, or are leading them to present themselves as, I'm a good person who uses drugs, or some of our questions even assumed that everyone that came in was heterosexual. And I was like, what? Well, how is this changing our interaction? And so those were questions that social anthropology helped me answer. Those were the tools I wanted to use. And so when I walk into the Odessa clinic and I see this, I'm like, ooh, tell me about this and how that's working. So I think the answer is both. I found data keeping interesting, and I was fortunate enough to meet people in Ukraine year after year after year who were willing to share their data keeping practices with me, and I guess I continued to find it interesting. Yeah.
Cool, thank you so much. And I see that Ruslana has also raised hand, so I assume she has a question for you.
Yes. Hi. Thank you once again for the great lecture. Yeah, I have a question. Actually, it's like more two questions combined in one. How do you see, like for you, what was the role of medicine and health related knowledge in your research, and how did you deal? I mean, I assume that you had certain gap because if I'm not mistaken, you did your degree in epidemiology after you did the research. How did you deal with the gap between anthropology and the knowledge you needed in the field? Because I'm going to the field soon, and I'm, to be honest, a bit nervous how I'm going to talk to microbiologists and how they are going to perceive me. Yeah, thank you.
Yeah, no, that's a great question. So the first chunk of research I did, and I keep mentioning the work in Odessa because that's where, excuse me, that's where some of the paperwork came from. But I was there in 2006, 2007, and then I went back, did more language study, got my master's or did most of the classwork for my epidemiology degree, and then went back to Ukraine 2012, 13, and 14. So the first time I had the personal knowledge of having worked in similar programs, and the second time I had more of an understanding. But I actually found that the thing that helped me have that dialogue and to be treated kind of like a peer with folks I was talking to didn't have to do with my expertise. It had to do with one, the fact that I came with academic credentials. So that meant that it was, even though I was not yet a doctor of philosophy, the medical doctors would be like, hey, you're one of us, you know, like, and would kind of see me as a peer in that way. But just the ability to know the language, like the jargon, not the language like speaking Ukrainian, the language like knowing, you know, slang or specialized terminology, because I found that people were less interested in ensuring that I was also an expert and were more interested in making sure that I just knew what was going on. So when I say like, okay, so if we want to teach you about what we do, do I have to start at the very beginning? You know, like if I was to walk in and say, this is my first time in the Ukraine, people would be like, okay, this is going to be a very long day when we unpack a lot of politics. And basically this is like at 101. But if you come in and you're like, oh, I've seen that at a similar place somewhere, or you're using language that just indicates that you have a basic understanding what's going on, I think that really helps. There's a woman who used to work for the Open Society Foundation named Sophie Pinkham. She's an American writer now, but she did a lot of work with these harm reduction programs. And she told me one time that she had studied Russian in college and then went to Ukraine and studied Russian more, and then spent a lot of time talking to people receiving the services. And only years later was she ever in a position to speak to like fancy researchers or who did I freeze up? Sorry. Only later was she in a position to speak to fancy researchers and important politicians. And she said, I scandalized them because I didn't realize that I spoke Russian like a prisoner. That I had like all of this really like just full of mat and like all kinds of like slang. They were just like, how is this petite little woman coming at us with this language? And so that was, I think, a recognition for her that she had been doing so well at her previous job because she could show up and talk like everyone else. And so just being able to talk like everyone else, knowing the names of different processes or anticipating what they're going to think is really fun or really frustrating, that to me had so much more of an impact on being welcomed into that conversation than any like medical expertise I had. People just want to feel understood. And so if they feel understood by you, they'll want to talk to you. Yeah. We all want someone to listen to how interesting we are, you know? So yeah, if they feel understood, that will be a huge help. Yeah. I will also say, I should add though, you will probably discover that you're already extremely good at what you do once you go out into the world. I feel like that's a classic experience for all like growing researchers, is that you think you don't know anything, and then you end up in a room with like ordinary people and you're like, oh, I know a lot. So I think you'll be surprised by how much you actually do know when you go. Yeah.
Thank you.
Ivan has asked a question. You obviously travel between different worlds speaking to anthropologists and medical folk. That is true. I was wondering about the feedback you were getting from medical audiences about your study in Ukraine, in particular, what kind of translations, cultural, contextual, methodological, and explanations you had to make yourself properly understood. Yes, so true. I find that anthropologists are more interested in learning about public health science than public health and medical scientists are interested in learning about anthropology. The skills are valued. And every time I joined a clinical research team, people would be like, oh, Jeenifer, do your thing, like as though qualitative research was some kind of sorcery. The challenge that I found was that, and I don't mean this in a bad way. I mean, like, they're terribly busy and medical articles are pretty short. And so when I would give what I thought was a very modest anthropological manuscript article for a journal to a medical co-author to read, they would be like, oh, this is 6,000 words, you know? And I'm like, that's very short for us. That's not very much. And it would take them like a month to get through it because most of their publications are like 1,000 words or two, I know. And oftentimes I would think I was using the simplest language ever. Like, will the people at the anthropology journal be like, you need to strengthen this because the language is so simple? And some of the physicians were like, I did not understand everything, but it reads very beautifully. Good job. So I think the challenge is really in articulating findings, not as theory, not as generalizations, but as small insights that make sense to them. So I did not succeed in teaching the last big partnership that I worked with the theory of hierarchy of resort. And I did not succeed in teaching them theories about embodiment. And I did not succeed in teaching them about the anthropological tool of explanatory models, but I was able to explain to them why all of their pain patients who had their opioid prescription ended were suddenly using more cocaine. Because the whole room was like, why is this happening? It makes no sense. And I like the one, this is what I mean when I say you'll go out there and you'll be surprised by how much you know. I was like, this is the most obvious, it's so obvious to me why this is happening. And I could tell them in that instance of like, well, it's about managing how your body feels. And you know what, when I drink a lot of coffee, when I'm out of coffee at my house, I might move over to sugar or something, like this is how we that's a very basic anthropological or social science insight. So I think making sure that you're providing chunks of information that they feel like they can use and that they can use immediately to make sense of what's in front of them is much more useful because, doctors are not against studying social theory. You don't like, if you mention Foucault on a meeting, they won't be like, ugh, and hang up on you, but they're busy. They're like, I could read Foucault, or I could go treat 2 more patients with HIV. I'm going to do that instead. So just being respectful of the fact that they are viciously practical, I think is very helpful.
Thank you so much for this wonderful conversation. I mean, I feel that we could keep going on and on and on until it's midnight here and everyone just goes to bed. But I think that probably we should stop while the time is still reasonable. And just,
I will mention though, Ivan mentioned my cat, and some people find it very funny. We named her Ulana Soprun. So this is Ulana, and over there on my couch we have Nadezhda Krupskaya, and these are our two cats. The veterinarian cannot pronounce their names, and it makes me laugh every single time they try to say it, and it's wonderful. So anyway, Ulana Soprun, everybody, thank you.
For what it's worth, we called our dog Doxa to honor Pierre Bourdieu.
Perfect. Yes. We'll have to name our next cat after Bourdieu, maybe.
All right. So thank you so much again. And thank you so much. Thanks to the center for organizing this lecture. And thanks for everyone. Thanks everyone really for coming and staying with us on a Friday evening.
Yes, thank you.
Yes. Thank you so much. And I guess take care, everyone. And this video will soon be posted on YouTube with Ukrainian subtitles. So make sure to spam everyone from your friends on Facebook. Let's spread knowledge.
Yeah, thank you. This was a lot of fun. And these were awesome questions. I loved hearing how everyone was thinking about it and responding. Thank you. I really enjoyed this.
Bye, everyone.